We'll move forward to the next session. Dr. Santosh Honavar, sir, needs no introduction. He has made outstanding contributions to ocular oncology, retinoblastoma management, and oculoplasty. A great teacher, researcher, and surgeon of exceptional caliber, whose visionary work has shaped national protocols, advanced scientific understanding, and given hope to countless patients and families. I take pride in inviting sir to deliver the masterclass. Thank you, sir.
Thank you so much. I thank Madhu for this kind invitation. Sorry for coming between you and lunch. Sujata has to leave, so I got it kind of preponed, I believe. So anyway, I'll be speaking about retinoblastoma, which is very close to my heart. And this one slide actually summarizes the advances that have happened in the realm of retinoblastoma in the last 125 years. In 1900s, we had 98% mortality. Now we have more than 98% survival. This kind of a turnaround hasn't happened in any other cancer except retinoblastoma. That's only because we keep adapting to newer ways of diagnosing and managing retinoblastoma. This is a classification, grouping system that we use. Grouping always prognosticate eye salvage. Group A is for small tumors, B is for bigger macular tumors with subretinal fluid close to the optic nerve. C, the words confined is denoted by C, confined subretinal or confined vitreous seeds in exophytic and endophytic retinoblastoma respectively. And D stands for diffuse. Diffuse subretinal or diffuse vitreous seeds becomes group D. And E were potentially enucleable eyes earlier. Now we are able to say about 70% of E as well. The diagnosis is very simple and straightforward. A good indirect ophthalmoscopy is all that is required to diagnose. Ultrasound B scan helps detect calcification and also measure the diameter and the height of the tumor for monitoring purposes. Otherwise, no investigation was required earlier. Now we mandatorily do MRI scan. That's because, as you see here, there is no proptosis in this patient, but look at the optic nerve. It is grossly thickened right up to the orbital apex. Obviously, you cannot do primary enucleation here, although that is the treatment of choice. So whenever there is an advanced retinoblastoma, we have to image. Now this patient has a small tumor, but look at the choroidal involvement. So when there is choroidal involvement, that becomes a high risk for systemic metastasis, and that's the reason you cannot give intraarterial chemotherapy to these patients, because the patient does not receive any chemotherapy at all systemically, which is important, otherwise there will be microscopic metastasis. So imaging has actually changed the way we triage these patients. If you were to enucleate, that is fine. Now we want to save eyes, that should not be at the cost of life. Basically, with that premise, we have to fully investigate these patients before we commit to a particular mode of treatment. For small tumors, there's always cryotherapy and photocoagulation, but this is not very good in terms of vision salvage. Mainly because cryo produces a scar which is much larger than the tumor that you began. Cryo is triple freeze thaw cryotherapy, which is very heavy cryotherapy. That results in a much larger scar. The retina surrounding the tumor actually gets frozen, and also multiple attempts at cryotherapy will result in atrophic retinal holes and rhegmatogenous retinal detachment. If you were to cryo a tumor which is close to the equator or anterior to the equator on the temporal side, there is always a risk of epiretinal membrane formation, because cryo causes desmoplastic activity, it shrinks the retina and pulls the retina away, so patient may not end up with 6/6 and 6 vision. So cryo is good but not very commonly used currently. Photocoagulation is mentioned only to be condemned because it is not a good modality at all. Why? Because the principle of photocoagulation is to cut off the blood supply to the tumor. And how do you do that? By surrounding it with large diameter laser burns, 2 rows of it. So a tumor which is this small will end up producing that larger scar. Look at the blood vessel carefully. It is blocked. So there is a problem with vascular occlusion as well. That apart, if a tumor were to be, say, in the superior juxtapapillary area, if you were to do photocoagulation, the nerve fibers will all be fried and the patient will end up with an inferior arcade scotoma. So it's not a good modality to treat if you are interested in salvaging vision. So what is the alternative? Alternative would be transpupillary thermotherapy. TTT also uses laser, but semiconductor diode laser that gently heats the tumor to about 55 to 65 degrees Celsius. When the tumor becomes subtle gray, then you stop doing TTT. It is always done on top of the tumor, never around it. So the scar is crisp, never larger than the tumor that you began with. And you can see all these even small blood vessels that are passing through this scar are patent. So the advantage of TTT is that you are much better in terms of vision conservation. You can see that the TTT has not caused any desmoplastic activity. There is no RP changes as well in this patient, which means that it does not pull on the retina or does not result in epiretinal membrane formation or tractional element. Now, what about patients who have recurred over an amelanotic scar? All forms of laser require a pigmented background, otherwise they don't take well. Now, this patient has recurred right in front of the optic nerve, right next to the optic nerve, on a previously regressed scar. This scar was regressed following chemotherapy, and now this patient has recurred. That is the recurrence, which is not easy to treat. So what we do is we do synergistic treatment with indocyanine green. Indocyanine green works in synergy with transpulpary thermotherapy for the frequency that we use, and these tumors go away. And that's the recent advance that we have been using. What about plaque brachytherapy? Plaque is classically indicated for tumors which are about 16 millimeter in diameter and up to 8 millimeter in thickness. Plaque is not new, but the designs are new. And how are we using these new designs? We are able to treat tumors which are right next to the optic nerve, which are otherwise very difficult to treat. Why did this patient need plaque at all? Because this patient had contraindication for chemotherapy. He had thalassemia major, where chemotherapy was relatively contraindicated. That is the reason why we had to use plaque brachytherapy here. And you can see nice regression of the tumor with a very healthy and preserved optic nerve. So designs are very promising. What is also promising is the Indian-made plaque. This has been made with the effluents of Kalpakam reactor that actually used to be discarded. With that, we have harvested ruthenium and we have made an Indian plaque with BARC, which has reduced the cost to less than 5%. So plaque is more affordable and it is more widely used in India now by more than 12 centers. Chemotherapy brought about a paradigm change. These articles from 1996, almost 30 years ago, that is exactly when chemotherapy came into the arena of retinoblastoma. Otherwise, we had enucleation and radiation. So 30 years back, chemotherapy came in, and these were the 4 articles published in Archives of Ophthalmology, now JAMA Ophthalmology, where chemotherapy was described. Never does any journal publish 4 articles on the same topic in the same issue. This was such an interesting and an important watershed zone that the journal decided to publish 4 articles on the same issue, on the same topic, all chemotherapy in retinoblastoma. That changed the entire management perspective. That was intravenous chemotherapy. It is actually chemo reduction. It reduces the size of the tumor. It's like going back in time. If you have a 16 millimeter diameter tumor, by giving chemotherapy, it becomes 12, 8, and 6, or whatever, 4. At that time, you hit it with laser so that you have a much smaller scar than the tumor that you began with. That is the beauty of chemo reduction or neoadjuvant chemotherapy. I'll show you some examples. This patient has this larger tumor and a smaller corresponding tumor there. Now, after chemotherapy, you have a much smaller and a compact scar. Macula is exposed. This is not possible with any other form of treatment. Maybe plaque to a certain extent, but otherwise the scar is almost as large as the tumor that you begin with. The second principle of chemotherapy is that tumor is very smart. It always hangs on to its source of blood supply. Tumors are very hungry for blood. And most of the posterior polar tumors obviously are supplied by one of the arcades, supratemporal, infratemporal, supranasal or infranasal. And this tumor is supplied by the supratemporal arcade. You can see here it is dipping into the tumor and the tumor is abutting on the fovea at the initial presentation. Following one cycle of chemotherapy, you can already see that the tumor has left the fovea macula and is moving towards its source of blood supply. After 3 cycles, the fovea macula is all healthy and the tumor has totally moved away from its macular location to its source of blood supply, which is supratemporal arcade. So you have a scar which moves away from the macula fovea in chemotherapy, and that is the reason we have a much better chance of gaining vision. And of course, subretinal fluid regresses very early in the course of treatment. That is the third mechanism. This remains still the standard of care in India, mainly because this is very inexpensive. This costs about 5,000 to 6,000 rupees, that's it. And very easily done in ophthalmic hospitals as well. But the problem with systemic chemotherapy is systemic complications. About 10% of patients will need blood transfusion. They need protection from infections. Parents really have to take care of them very well. Those are the issues. And also the eye salvage is slightly less with intravenous chemotherapy, specifically in group D and D retinoblastoma. But what is the standard of care world over currently? World over standard of care is intra-arterial chemotherapy. We have the technology, we have nearly 100% cannulation success, but the cost is a barrier. Trying to make a catheter with IIT Mumbai, but that may take a few years, but until then it is quite expensive. In intra-arterial chemotherapy, we use a set of 3 drugs, melphalan, topotecan, and carboplatin. Interventional neuroradiologist in a cath lab situation anesthetizes the child and gets us access to the ophthalmic artery. Then it is our duty to monitor that the flow is constant. Otherwise, if the ophthalmic artery goes into spasm, they're not bothered. But we should be bothered because we are talking about vision here and constantly monitoring the perfusion into the ophthalmic artery. We inject these drugs very, very slowly in a pulsatile manner, not entering the ophthalmic artery directly, but right into the ostium, peeping into it without any spasm. And then the drug works beautifully well. This is total exudative retinal bullous, exudative retinal detachment settled into a compact calcified scar, larger tumor, 3 cycles, much smaller scar. You can again see that the disc is now seen, macula is seen, much larger tumor reduced to a calcified scar. Even the vitreous seeds here have reduced. So intra-arterial chemotherapy is very effective, very expensive, but at the same time, it gives an additional eye salvage of 10 to 15% in group D and E retinoblastoma. For C, it really doesn't change the eye salvage rate. So D and D retinoblastoma, we consider intra-arterial chemotherapy. Now, what about the vitreous seeds? Vitreous seeds were always the bugbear in the management of retinoblastoma. There was never a good cure for vitreous seeds. We gave chemotherapy and hoped that they would go away, but they didn't go away, and finally we had to enucleate them. Now we have a new classification for vitreous seeds. We call them intraocular seeds, and based on OCT, we have classic vitreous seeds. Of course, they are what is seen here. We have prehyaloid, subhyaloid, epiretinal, intraretinal, and subretinal seeds, and also intracameral seeds. Intracameral seeds are anterior chamber seeds, which may be depository, which simply walk through the zonule and come into the anterior chamber, or infiltrative, which come contiguously through ciliary body, iris invasion, trabecular meshwork extension, and into the anterior chamber. Now, for intravitreal chemotherapy, we have 2 drugs, melphalan and topotecan, but melphalan is toxic to the retina in pigmented eyes, so we use topotecan. And couple of injections, generally 2 to 3 injections is all that is required to take away these seeds. But the criteria here is that it should be safety enhanced, which means that there should be no risk of extraocular extension of retinoblastoma when you do intravitreal chemotherapy. So once the retinal tumor regresses nearly, from a safe clock hour, at least 3 clock hours away from any scar or vitreous seeds, you go into the vitreous cavity and inject these drugs. The results are quite dramatic. You can see this bunch of vitreous seeds all gone after 2 doses of intravitreal topotecan, all calcified again after a couple of injections. Now we have also high-dose chemotherapy. Initially we started with 30. Now with these resistant seeds, high-dose chemotherapy works beautifully well. We have gone up to 90 to 100 microgram of topotecan without any retinal toxicity. So that is actually what we have learned in the last 1 year to use high-dose intravitreal topotecan. You can see all this cloud of vitreous seeds that was obscuring the scar lying behind, gone after 3 injections of high-dose intravitreal topotecan. We also have a combination therapy. Intravitreal topotecan can be combined with low-dose melphalan. This is a patient when he began treating this patient, intravenous chemotherapy, the tumor is gone, vitreous seeds are exactly the same as pre-treatment. So in vitreous intravitreal chemotherapy era, this patient would have either received radiation or enucleation because we have given maximum chemotherapy and the seeds are still there. Now with intravitreal chemotherapy, the seeds have reduced, topotecan, but they're still there. Then we added low-dose melphalan and the seeds finally went away. So we have a combination of treatment that are available. Early results were published, long-term results were published, and finally a Survey of Ophthalmology review article on intraocular seeds. This you can read to learn everything about intraocular seeds in retinoblastoma, published very recently in August. Extended indications for intraocular chemotherapy would be anterior chamber chemotherapy. We were worried that endothelial toxicity may be there, but that really hasn't happened. We use a low dose of 5 microgram here and also intravitreal chemotherapy for epiretinal and subretinal seeds. The next bit is about enucleation. Enucleation is still performed in about 10 to 30% of children with retinoblastoma all over the country. We have learned that minimal manipulation enucleation with a long optics nerve stump, 18 to 20 millimeter, is essential. We have also learned that we have to look for high-risk factors. These are histopathological high-risk factors which are present in about half the Indian eyes. And when these histopathological risk factors are present, we are supposed to treat them with adjuvant therapy. What if we don't treat them with adjuvant therapy? About a quarter of these children die with systemic metastasis. So if you do a enucleation and leave the child alone, you may have done the best possible surgical technique, but about 1/4 of these children ultimately die because of systemic metastasis, not because of tumor recurrence in the orbit. If you were to identify high-risk factors and treat them with adjuvant therapy, then the chance of metastasis can be reduced to less than 5%. So just by this one measure, which costs less than 30,000 rupees, the entire treatment, you have reduced mortality in 20% of children, which I think is a very big number. So identification of high-risk factors with histopathology is important. That has really changed. Now the last part is about orbital retinoblastoma. It had 70% mortality, and now we use what is called multimodal treatment. Multimodal treatment is a combination of chemotherapy, surgery, and radiation in a particular sequence. For example, this child, for the orbital component, received neoadjuvant chemotherapy. He had obviously, eye went into phthisis. Then you do the enucleation with a long optic nerve stump and then give radiation to the microscopic residual and give additional 6 cycles of chemotherapy as adjuvant treatment. So this is a year-long treatment, and the advantages are plenty. You can see optic nerve invasion here, right up to the orbital apex, completely resolved, making it safe for enucleation. This child has cavernous sinus involvement, earlier considered untreatable. They would be just given palliative treatment. Now it is easily curable. All this is gone, and what is left at the superior orbital fissure is easily treatable by stereotactic radiation. This child can survive now. But I consider cosmesis as the greatest gift to these children. These children can actually wear a prosthetic eye. They don't have to undergo orbital excitation. Their lid is intact, and they can wear a prosthetic eye. You can see this child following multimodal therapy and enucleation and a nice prosthetic eye. This child had eyelid infiltration as well, and even that goes away. Lid has become nice and flat, and the child is able to use a cosmetically gratifying artificial eye. So orbital RB also now has a cure. So in 2025, as we come to the end of 2025, overall in India, we have 95 to 98% eye salvage, especially in major centers. In some of the centers, we have up to 98% life salvage. About 20% of eyes still require primary enucleation because they come in an advanced stage. Chemotherapy has 90% eye salvage overall, but about 60 to 70% in group E eye. So it's important to recognize retinoblastoma early. 95% where you save the eye have some vision. It depends on the location of the scar. With all the measures that I described, the scar location can be optimized as you have seen, and about 50% end up having vision, 25, 40 or more. These children, despite having poor vision, are able to do well in life and school. You can see this child has a macular scar but is able to produce such beautiful artwork. This child has one artificial eye and the other eye a macular scar, but she is able to play music so well. So all these children actually do well, and they are not different from any other children when they grow up. So in conclusion, I would say that Group A retinoblastoma, focal treatment with 100% eye salvage. Group B, visually challenging situations, you would do chemotherapy. C, D, and D, obviously chemotherapy. For D and D, you would prefer intra-arterial chemotherapy. Thank you so much.
Thank you, Dr. Santosh. I'm really happy to see so much advancement in retinoblastoma management. In 1992-93, when I was there in Arvind, I was doing so many enucleations, some days even 4 or 5 enucleations for the small children. Even other enucleation means making them totally blind. I was not able to eat my food also on the days when I was doing, and Reggie Madam was referring all the cases of enucleations to my department. Now I am seeing so much advancement in retinoblastoma. I am really, really very happy, Santosh. So they are surviving, their eyes are salvaged, and so cosmetically also they are much better. I am very happy to see the advancement, and your presentation also excellent. Thank you very much.
I would like to invite Dr. K.V. Apparao sir and Dr. Ramanraju sir to the stage, please, to give away the memento.